Okay, so we're going to get on now with a pre-recorded live case. Some of this is me talking on the video, but and I'll just watch the time, but this was a 68-year-old male. Typical risk factors, an insulin-dependent diabetic, chronic renal failure. So we know already the patient's going to have femoropopliteal and tibial calcified disease, and it's going to be medial and intimal calcification. Rutherford 5 bilateral heel ulcers in the posterior tibial angiosome. Treated the left leg on the 20th of March, and then the right leg is the one that we recorded a week or so ago. So there's an MR angiogram, and you can see there are multifocal calcified stenoses. Obviously, I say calcified, we've certainly got used to the morphology on MR angiography and predicting calcium, and there are some new MR sequences that can tell us how calcified this is. But you can see bilateral femoropopliteal segment calcification. You can see there's dominant anterior tibial runoff on both sides, but there are these focal left AT stenoses on both sides. So this was the lesion that we treated first. Look how severe this calcium is. This is a little bit different to the one that Thomas showed, but this is real-world, multifocal, both concentric and polypoid calcification, and you can see it on the left all the way down into the popliteal artery. Not only that, look at the density of this calcium here in the tibio-peroneal trunk and this typical linear calcification that we see, medial calcification in the anterior tibial artery. So this is just a different view of that calcified stenotic disease. And you can see that the anterior tibial artery has this further stenosis here. Now, admittedly, there's not great perfusion to the heel, but we felt that we should target the tibio-peroneal trunk to improve that peroneal flow and also perform anterior tibial artery intravascular lithotripsy. This is what you've seen already from and this balloon kept at 4 atmospheres, slowly opening up as shockwave is being performed, as lithotripsy is being performed. Look at that balloon, no pressure change, the balloon opening up, popping out. You just can't do that unless you're getting a compliance change in the balloon. And we performed intravascular lithotripsy right through the popliteal, the superficial femoral artery, and the above-knee popliteal artery, and followed that with drug-coated balloon angioplasty. And this is the kind of result we obtained before and after, and to the question of needing a stent. I mean, this would be the kind of case you'd be thinking you'd reline the whole thing with Supera. This is what we got purely with the balloon-based technology. There you see again in the popliteal, in the distal superficial femoral and popliteal arteries. Now I want to show you that we then used the below-knee device, the brand new, and it's just being released here for the first time at Charing Cross, the S4 catheter. So this is a specifically designed below-the-knee catheter, 5 French compatible, hydrophilic catheter with good pushability, so excellent for primary passage through some of this severe disease on an 014 platform, available between 2.5 and 4 millimeters in diameter and on a 4 centimeter length. We're going to treat the tibio-peroneal trunk stenosis. So this is the Shockwave S4 catheter. This is a 4 millimeter diameter, 40 millimeter long balloon catheter. Once again, you can see it's got a wire in the central lumen, and it comes with also an outer cover which we'll take off here. 4 centimeter long catheter here. We'll just flush the tip through the guide wire lumen, and then in the same way as the femoropopliteal device, we need to once again deaerate the balloon so that we maximize fluid wall contact during lithotripsy, and so we just do that by aspirating. Actually, in our limited experience with this catheter, it's actually considerably easier to deaerate than the femoropopliteal device. So to keep things moving, I think we'll leave that there. There you can see that we've performed intravascular lithotripsy on the tibio-peroneal trunk. That opened up very nicely, and we got a good angiographic result with a minimal residual stenosis. This is again a lesion you would often think you'd need a balloon expandable drug-eluting stent to treat this. And then right through that anterior tibial artery, performed intravascular lithotripsy. And here is the before and after that we achieved really with this purely catheter-based strategy for the below-knee arteries in excellent results. So let's switch to the right side, and some of this again is pre-recorded. Today we're underway with the right leg intervention. By the way, he's done very well clinically on the left side and reports that his left foot is warmer than he can remember for a long time, which is very pleasing. So we've gone antegrade right common femoral artery puncture with placement of a 6 French sheath to facilitate this intervention. And you can see on this first image the severe calcification throughout the femoropopliteal segment. If we just go through the subtracted images, multifocal stenotic disease with polypoid type calcification, and then a very critical stenosis at the junction of the distal SFA and the above knee popliteal artery. Next run, thanks. Now we can just unsubtract that, thanks, and you can see that calcium again through P1, P2 and into P3. And around about the ruler, around about the 50 or 55 mark, you can see the typical medial calcification that we see in a long-standing diabetic and chronic renal failure patient such as this one. You can see that extensive medial calcification in the tibial artery. So an interesting case. If we go forward with the subtracted images, then you can see that critical stenosis of the distal FCFA above knee popliteal, further P1 stenotic disease, then P2, P3 look good, as is the anterior tibial artery. Perineal and posterior tibial are patent but diseased. Next run, thanks. And here you can see that the anterior tibial artery actually is a good quality vessel. It's got no significant stenotic disease. We do have a localized occlusion of the posterior tibial artery. So in the interest of time, I wanted to just carry on. You can see this patient primarily on this side, we were going to treat the femoropopliteal segment because the AT was really providing collateral supply to the heel. So we didn't need to do any below the knee treatment. But you can see this is the femoropopliteal treatment. The catheter over the 014 stiff guide wire. Thanks to the design of the nose cone, you got that fixed. And the catheter itself. Find that this will primarily deliver through critical stenotic disease very nicely. If we can go to medium resolution, thanks, and we won't have overlay on at the moment. So we're just taking this catheter down, and I expect, despite the fact that it's quite severe calcium and stenotic disease, that's passed very freely through the stenoses there. We can bring the overlay back on, thanks. So that's pretty good positioning there. Oh, there is actually a stenosis a little further down, isn't there? So we can deal with that. All right, so we're in a position now to perform lithotripsy. So we're going to now connect the generator. And to do that, we just use a sterile ultrasound probe cover and drape that over the generator. I like to create a little bit of redundancy in this, and then we just cut the tip of that. There's obviously different ways to do this. This is just the way we do this. We're now advancing an unsterile tip of the generator, but connecting, re-advancing, and then securing to keep sterility, the generator connected. Okay, so what we're going to do is just inflate this slowly up to 4 atmospheres. We're really looking to get angioplasty balloon vessel wall apposition. As you can see there, we're demonstrating some stenotic disease, and we're performing some low pressure angioplasty. You can see how resistant that stenosis is. Now we're going to start lithotripsy. Okay, thanks, away we go. Pressure dropped on the balloon, so we just keep that open. And you can see, just maintaining pressure, how the balloon is growing in terms of luminal gain through that resistant area of stenosis. I think the balloon sizing is nice here, just slightly just over 1 to 1. So this catheter is capable of 6 cycles of 30 seconds, and we just might... Okay. So again, we treated very much as on the left side, multiple lithotripsy throughout the entire calcified femoropopliteal segment. And then you can see us using drug-coated balloon angioplasty here. Again, just as Thomas does, this is a routine thing. Here you can see we're taking this angioplasty balloon, which is a Medtronic impact SFA balloon. This is a 6 millimetre balloon, 120 long. And treated the entire segment with DCB angioplasty. It's very, very good, doesn't it? So that was again the the completion angiography, which really again is a dramatic improvement over a very extensive and heavily calcified segment. As I say, we didn't do reconstruction of the tibial arteries on this particular case. All right, so this has been a very interesting case today and an interesting challenge for this patient. Has had bilateral critical limb ischemia and heavy calcification in both the femoropopliteal and tibial arteries as a consequence of chronic renal failure and diabetes. But with Shockwave lithotripsy, we've been able to treat the femoropopliteal segments and also follow that with drug-coated balloon angioplasty. On the right side, actually, the anterior tibial artery is providing good perfusion to the foot, and we didn't really find a tibial site that we can improve perfusion besides that. But on the left side, we obviously had very nice experience with the balloon and the S4 device to treat calcified tibial artery disease with a very nice result. Thanks very much.